for a talk is titled, part of the CWRH lecture series, titled COVID-19 in 2022, Managing New Waves and the Impact on Women's Health. Some of these speakers are not strangers to you guys. I know Dr. Lee has come and talked to us previously, I guess 2 Marches ago, right before all this got started. And then Dr. Dionne, a lot of us have worked with her in the past for research, but is also one of our collaborators in infectious disease. So just to introduce them a little bit, Dr. Dionne is a associate professor in the Division of Infectious Disease. She is the chief of women's health at the UAB 19th Century HIV Clinic, and as well as a prolific researcher, and has been working on a lot of global health, infectious disease, maternal child transmission studies with the CWRH. So currently she is funded. She has an R01 looking at hepatitis B in Cameroon. And I'm fortunate enough to call her a collaborator on many efforts that we have done together looking at syphilis and chlamydia here in our population. Dr. Lee, as I mentioned, has come and spoken to us before involving COVID back in 2020, and I think also maybe in 2021. So she's also an associate professor in the Division of Medicine and Infectious Disease, and most notably has been leading up some of the COVID efforts here from an epidemiologic perspective at UAB. So without further ado, I'm going to turn it over to them and let them get started. Thank you guys a lot for joining us, and we're really excited to hear what the updates are.
Yes, thank you for having us. I'm going to share my screen first, and then I'll hand it over to Jodie after. Hopefully you can see my slides okay. As Akila was mentioning, I've been able to give this talk a couple of times with Dr. Marazzo, and every time I look back into the slides, it breaks my heart a little bit to see how many cases of COVID we have had and how many deaths. But I think there's some hope on the horizon, and hopefully we can talk a little bit about that going forward.
You want to go inside? No. If you're cold, I'll go inside. No.
Can you see that okay?
Okay.
Okay, so here's our outline for today. We're going to talk about COVID-19 epidemiology. We'll talk about some outcomes and infection in the general public as well as in women, then on to treatment, followed by prevention, and then inclusion in some clinical trials. So this is what I was mentioning before. So this is COVID-19 after 2 years of dealing with this pandemic. You can see that we have topped over 70 million cases since the beginning of the pandemic. And one of the biggest and most striking things is the amount of cases that we are seeing with this surge right now. So this is data from the New York Times. You can see that this Omicron variant has really led to a large number of cases. We are doing over 2 million tests, which is an increase of about 15% over the past 14 days. And while those cases are beginning to drop, we are still seeing a large portion of patients that are hospitalized, and our deaths are continuing to lag. So our deaths are up by 34%. So we've reached astronomical numbers in the United States with a total reported death of about 877,000. When we look at Alabama, the numbers look very similar to what we are seeing in the United States. So our cases have topped and are coming down. Alabama was performing over 25,000 PCR tests per day. And as a reminder, these graphs do not capture our home COVID tests. The average positivity rate was 45% as of a few days ago, which is some of the highest in the nation. And our cases are dropping, but unfortunately, as you can see here, our hospitalizations are yet to peak. I think one of the interesting things here, at least in Alabama, is that our cases have remained high for a prolonged period of time. And I think a lot of this is driven through our K through 12 system, school system. So the ADPH said last week that over 26,000 kids in the K through 12 grades were reported to Alabama as being positive for COVID. And recent articles have shown that 1 in 3 children are in virtual learning this week in Alabama. So if you think about the impact that it has on us as a hospital system, if you have children that are out with COVID, you have to stay home with them, and you potentially could get exposed and then contract COVID as well. So that we have seen cause issues in our healthcare system. Now, we are lucky to have some great epidemiologists at UAB, and so Dr. Russell Griffin has been following these UAB projections, and he's made statewide projections as well as Alabama and, UAB projections. And so what I'm showing you here is what we are hopefully seeing as us cresting over our UAB hospital admission census. So statewide, we did likely peak in our cases on January 9th of 2022. And what's been interesting is that we've been really flat in our COVID census in our hospitalization this past week. And about in the past couple of days, we've started to see a little bit of relief and decrease in our hospitalizations. And that's really reflective in our new positive daily patients that are being admitted to our hospital. And if you look at our UAB employee numbers, they've been hit very hard with Omicron, but those numbers are easing up as well. So all indications are hopefully leading to this surge going down. Now, what is unique about Omicron? It remains the dominant variant worldwide. And if you look at this graph on the right, this orange color actually represents Delta. And somewhere around December 11th to December 18th, we saw Omicron initially peek its head into our US cases. And then within 3 weeks, it has become the dominant variant. So it just really overtook very quickly. And this is likely related to the fact that it is highly transmissible from person to person. So 99% of the cases that are being tested right now are Omicron. I know that our last sequencing done at UAB was 100% Omicron. What makes Omicron so very difficult is when you think about outbreak investigation, the median incubation period is about 3 days, but it can be as short as 33 hours. So if you think about contact tracing to try to initiate isolation and quarantine, it really can be not as useful in the setting of Omicron because that secondary group and that transmission has already occurred and they may already be symptomatic. So you're already down the line in terms of trying to control this outbreak. We know that there have been a high frequency of asymptomatic infections. And in fact, when we look at some of our employee health data, there are very few symptoms people may be testing because they have someone at home that's positive and they have maybe a runny nose, maybe a slight cough, but nothing compared to what we have been seeing in the past. And then increasing cases are likely due to this thought process that Omicron can escape from our natural immunity, as well as our primary series of COVID-19 vaccines. I'll show some more data about this and about this escape from vaccine in the coming slides. The other issues here is that, if we think about the home antigen tests that we've been sending out, I know anecdotally we've been hearing about how these antigen tests have been negative, but then the PCR has been positive. And if you look, there's been some early studies that have shown that antigen tests may be falsely negative in up to the first couple of days. There are a lot of unknowns here with Omicron. So we don't know if it's going to cause long COVID syndrome, which is something that we've heard very frequently with the other variants. We do not know about the duration and the extent of immunity following Omicron. I've had a fair amount of people say, if I've had Omicron, can I get Omicron again? And we have absolutely no idea. We don't know if we need an Omicron specific booster. And there's been a lot of information in the media about improving your masks, but we actually have no clinical trials that have looked at N95s or KN95s use in the general public and whether or not that will reduce COVID transmission. Not to say that we shouldn't have that data, but we just have no idea going forward. So here's some interesting data about antigen testing. This was a study of 731 people. It's a preprint, so it hasn't been peer reviewed yet. But in 731 people that walked up to testing in San Francisco, they looked at nasal antigen tests compared to nasal PCR tests. And so overall of these 731 individuals, 40% tested positive with a PCR. And then among those people who were positive for PCR and had no symptoms, so they were asymptomatic, the antigen test lost some of its sensitivity. So it was about 89%. But if you had a positive PCR and you were symptomatic, your antigen test actually mirrored very well with the PCR test. So it was about 97.6%. And you can see that there are these different thresholds that we look at. So this just graph to orient you. So these are the sample numbers. And we look at something called a cycle threshold. So that's how many times a PCR can turn over in order to detect virus. So lower means that there's a higher amount of virus. What we have in our system at UAB, at a cycle threshold less than 30, we can send that off for sequencing typically. Anything greater than 35 has been very hard to culture in the literature. And so that decoupling you can see here happens when the PCR has a higher cycle threshold compared to the antigen, which is what is showing here in this yellow line right here. So let's talk about some fact checking and things that I have heard in the media and in other ID circles. So do vaccines prevent Omicron? The answer is yes. This is a simple answer. Overall, in December, CDC found that when comparing fully vaccinated patients, the monthly rates of COVID-19 associated hospitalizations overall were 16 times higher in unvaccinated adults compared to vaccinated. Now, this is pre-Omicron data, but this is really very, very strong data to support vaccination in a wide variety of populations. Even in our adolescents who are typically healthy, it's 9 times higher in unvaccinated adolescents who were hospitalized compared to their vaccinated counterparts, and up to 17 times higher in adults age over 65. When you look at this stark difference in the age-adjusted rates of COVID-19, you can see on this graph on the left-hand side, this blue rate is the rate of unvaccinated individuals here. And then the green line is the rate of fully vaccinated persons that come in with hospitalization due to COVID-19. What's even more striking is if you break this down further by unvaccinated, which is the orange line, those who are fully vaccinated with an additional dose, which is that light blue, or just fully vaccinated without a booster dose. And so there appears to be that even more data to say that getting a booster may be helpful in preventing more hospitalizations. Now, as of December 1st at UAB, COVID positive patients that were admitted to our system, about 1 in 10 were likely to be unvaccinated. 1 in 20 were fully vaccinated, and 1 in 40 were boosted. At the time that I talked with Dr. Griffin, who gave me that data, there were only 4 patients that had been admitted that were documented as being boosted for COVID-19. So all that to say, boosters are helpful in the preventing of hospitalizations. Now, you may be asking, well, what about symptomatic disease? You've been telling me that we're seeing a lot of employees that are getting sick. Well, that is true. There has been some data from the WHO that has looked at these different vaccines that we have. And so on the top left here, this CHAD is actually AstraZeneca. And one of the interesting things that they found here, that a 2-dose series of AstraZeneca had no vaccine effectiveness against Omicron, which is the circles right here compared to Delta. A booster dose, if you got a booster with mRNA, that increased that vaccine effectiveness up to 40 to 70%. Now, for the Pfizer vaccine, you can see that a 2-dose vaccine effectiveness was down to less than 20% by week 15. But with a booster dose, that increased the vaccine effectiveness up to 40 to 80%. In Alabama, I will say that while we have increased the number of our primary series with COVID vaccination, we have a very small portion that's been boosted. And so I think that's maybe some of the reasons why we're seeing a lot of patients being admitted right now in Alabama. Now, that data that I just showed you was data on the Petri dish. And now this is real world data that has been comparing Delta to Omicron, looking at symptomatic disease. So this was a case control study. So 13,000 cases of Omicron were compared to about 10,000 cases of Delta, and then 46,000 negative controls. And so under these patients who came in with COVID-like illness in the United States in December of 2021, those who had received 3 doses of an mRNA vaccine were less likely to be among the cases of symptomatic COVID-19. So it's kind of a flipped way to think about it, but that adjusted OR is 0.065 if you had Delta and had 3 doses of the vaccine, or 0.33. So these findings suggest that vaccination with 3 doses of mRNA compared to unvaccinated, and even though compared to those with 2 doses of vaccine, was associated with protection with both Omicron and Delta. Although I will say that that higher odds ratio that you see with Omicron may suggest less protection compared to Delta. So let's take the second question. Is the Omicron variant milder? I think this has been one of the hardest things to tease out, because we are dealing with a variant in the setting of having a high amount of vaccination. And so it's very difficult to tease out if it is milder if you are fully vaccinated. I think we were all waiting for South Africa to show some of this data because they finally peaked in terms of their deaths. So when you look at this data, here's their Omicron wave. So their cases were incredibly high and have come down. Their test positivity has come down as well. Their hospital admissions started coming down, and then their deaths are right here. So the Delta wave is this darker blue color, and then Omicron is here. So in South Africa, they are reporting that their deaths peaked at about 20% of Delta's peak. But one of the things that we have to think about as a country is the fact that the number of cases that we are seeing of Omicron overwhelm our system. And so this is what this data is showing from MMWR. During this Omicron period right here, the number of cases have skyrocketed. The number of ER admissions with COVID-19 discharge diagnosis have skyrocketed. And then that has led to an increase in confirmed admissions. And while we haven't seen deaths yet, because it is a bit early, that is our concern. If you are unvaccinated and being admitted for COVID-19, you may still have issues with pneumonia, et cetera. I think the CDC sums this up pretty well, that Omicron may cause a milder illness, but this record number of cases that we're seeing still leads to a record number of hospital admissions, 5 times higher compared to Delta and 1.8 times higher compared to Omicron. Now, I know that y'all are feeling this as well, and this data is our UAB data from Dr. Griffin, and it's looking at that 7-day moving average of COVID-19, and if you had a diagnosis of pregnancy and you came into the high-risk OB, to labor and delivery, to MBU or MEU. So specifically just into the OB related units. This is not even capturing some of our patients that required ICU hospitalization and are pregnant. And Omicron by far and away is leading in terms of the number of cases that you are seeing day in and day out, but almost twice the amount of numbers. So I think this is just reflective of everything that we are feeling with this surge. And as healthcare workers, it's been quite difficult to deal with it. Now, one of the things that you may have heard in the literature is this discussion about incidental cases versus primary cases. And this is data from Massachusetts, and you can see that they define incidental as being hospitalized due to COVID-19 if they received dexamethasone treatment, because they thought that dexamethasone would be an indicator of severe COVID-19. And so on average, they were having about 49% incidental and 51% related to primary. And I'm sorry, I said that was how they define incidental. That's how they define primary COVID-19 hospitalizations. I apologize. In a similar fashion, we have done this with our own data. So to orient you to this, on the top is our incidental cases, and on the bottom is our primary cases. So it's almost an even split. We've had about anywhere from 100 to 150 primary cases, and a little bit less on the incidental. So now we define this as being admitted to the MICU, to the MCCU, the hospitalist floors, and S9 South. Now you can see that we're obviously missing some of our pregnant patients that may have symptoms as well, or we may be allowing for more people on the hospitalist floors that may be here for something else. But even when we tried to look at it based on their reason for admission, the numbers were about the same, or at least the percent difference. So what does the epidemiology say? So we are showing this decoupling between cases, admissions, and deaths. but we're still seeing a continued high level of hospitalization and ICU admission. And it's unclear if there are these clinical markers that are associated with severity that are being picked up as easily or associated with Omicron. What I will say, when you look at those incidental cases, it's really hard to say if they're truly incidental or if COVID-19 is triggering exacerbation of a chronic infection. If you have a patient that has diabetes and they're coming in because they're having DKA because they weren't eating, or if you became dizzy and you fell and you had orthopedic break, those things, can you say that it's truly incidental, or is it COVID-19 that's triggering those admissions? It's really hard to tell at this point. So here's my last fact check before I send it over to Jodie. So is Omicron airborne? There is a group of individuals, at least they're very vocal on Twitter, that talk about how Omicron is airborne and we should really improve our masks. So I wanted to try to dive into that data to see where we're at with it. So when we first heard about Omicron in the news, it was this case that happened, this large Christmas party that occurred in Norway. So 110 people gathered at this Christmas party. They were mostly vaccinated. One person had returned from South Africa. And within a very short period of time, nearly 70% of the partygoers were infected in this outbreak. And so that in and of itself is a very concerning number of people in a very short amount of time that were exposed and positive. So why do we think Omicron is outcompeting Delta so quickly? So there are a few hypotheses. Number one, immune evasion. So can it evade our natural and our vaccine-induced antibodies? And the answer, it appears, is yes, it can. Does it have a higher and or earlier viral load peak? Well, we're not sure about the higher peak, but we can say that you're having symptoms and showing up symptoms sooner, so that may lead to transmission more frequently. Is it more airborne? Are we seeing more asymptomatic spread or that shorter incubation period? And I think we haven't fully answered these questions yet. So these are just hypotheses and I truly don't know the answer. What I can say, and I go back to a lot about our routes of COVID-19 transmission, and we all know that droplet is very important. It's probably it is definitely the major mode of spread from person to person. There's thought that it can be on the environment and can be stable there. It's really hard to tease that out in case reports, because if you touch a surface that is wet, you're probably within a very short period distance from someone that's also infected. So typically droplet and environmental contact occur at the same time. And then we have the question about aerosols and airborne transmission. So I like to orient people to airborne, aerosols, droplets, nuclei, because those terms are thrown out very easily in the literature, but I think it's helpful to have a clear definition. Aerosols are an overarching term. It includes the broad range of particles. Droplets are the larger ones that kind of fall to the ground within 6 feet. And then droplet nuclei are the smaller ones that kind of remain suspended in air and can evaporate quickly. They can leave behind parts of particles or viruses suspended, but typically they don't last for a prolonged period of typically only a couple of hours. These are the ones that we get concerned about when we think about measles, because they are capable of riding air currents through a hospital and other places. When we think about those kind of small floating nuclei, they can be very variable and they depend on the size, the propulsive force. If you have someone that is coughing a lot, sneezing, not wearing a mask, that can move and propel that much further compared to someone who is wearing a mask and maybe not coughing. We think about crowding and temperature and air changes and airflow a lot of times when we talk about how these move. So for the longest time, I used to think that droplet is on one side, airborne is on the other side, never the two shall meet. But I think there has been a lot more understanding of this small particle aerosol transmission, which is maybe where Omicron falls in terms of being able to spread. So it can spread when we're in poorly ventilated spaces with very large amounts of virus. When we think about true airborne pathogens, measles by far and away is a high R0 of 12 to 18, but household attack rates are greater than 90%. With COVID-19, the original strain had a household attack rate of about 10%. With the Delta, the R naught is 7, and the household attack rate ranged from 11.3 to 25.8%. And there was a huge decoupling between vaccinated versus unvaccinated. Now with Omicron, this is the data coming out of UK. You can see here that Delta is on the top and then Omicron is on the bottom. The secondary attack rate that they have been describing is around 13.6% for Omicron. And then for non-household contact, it's about 7.6%. Now, there's another study that is looking at Danish households and found an attack rate of 31%. I will tell you that I've heard of whole households being knocked out by Omicron very quickly. So it's hard to know where we're going to land with this data. This is still preprint early data. So what does our future hold? You may have heard about the subvariant of Omicron called BA.2. If you look at this top picture here, BA1 is going to be your Omicron, BA2 is the one that we're concerned about. There are 85 mutations rather than the 60 that Omicron has. What's concerning about this is that it lacks certain spike mutations to allow lab to tell if it's Omicron. So it's being dubbed the stealth Omicron. And if you look at UK data, it's doubling every 4 days, and it started to take hold in Denmark, India, and Philippines. And that's what this picture is showing down here. The purple is the BA2, and you can see that green was Omicron, and so we've already in Denmark started to see the BA.2. So with that data, it makes us think that it's even more transmissible than Omicron, but really early data says that there's no severity disease severity difference. And immunity is completely unknown because we have no idea what's going to happen in the setting of Omicron. I don't mean to end on a scary slide, but hopefully this gets us thinking of how in the world are we going to get out of this pandemic. I think I will stop sharing and allow Jodie to share.
Hey everyone, hopefully you can hear me. Now that you are all experts in Omicron, what I want to do for the next 30 minutes is continue to talk about everyone's least favorite pandemic in light of what the outcomes are, in light of what the new data is on treatment and prevention. And I did this in the same way that Dr. Lee did, the most common questions I'm getting from clinicians, from patients, and from the public. So to start with the basics, what do we know about COVID-19 infection outcomes in women? Interestingly, since the early days, we've seen that women are more likely to come down with COVID-19 if you include mildly symptomatic cases and asymptomatic cases. This CDC data is particularly, the difference is particularly stark when you look at the age group 20 to 29. So this is thought to be likely a manifestation of women being frontline workers, caregivers to other people, probably more likely exposed. On the other hand, when you look at severe disease outcomes, like ICU admission, like deaths, you do see a difference where males are more likely to have these severe outcomes compared to females. And this data from CDC shows you this doesn't matter whether you have underlying health conditions or not. And that always begs the question of why, what's really happening? And COVID is letting us understand some differences in immune response that we really haven't understood until now. This is a nice study that was published in Nature last year, where they looked at patients who were hospitalized with moderate COVID-19. You can see the age on the bottom and some markers of immune function on the y-axis. The first is activated CD8 cells, and the second is a measure of interferon production by CD8 cells. And what you see, particularly in the older groups, is the value of this type of stratified data. The females had much better immune response, better immune function compared to males. And this may be part of the reason why males have more severe disease. More to learn, but certainly interesting. So what about fertility outcomes in adults who are trying to conceive? I know this is one of the most common questions that you're getting. And it's really been pernicious since day one that COVID has an impact on fertility. So let's look at the data. Fortunately, in 2022, we're finally getting good quality information. So the first study I want to share with you was just published this month in the American Journal of Epidemiology. It's a prospective cohort study out of Boston called PRESTO, where they enrolled 2,100 females in the US and in Canada between age 21 and 45, trying to conceive without assisted reproductive therapy for less than 6 cycles. They were able to capture these people that don't always present for care by doing a bi-monthly internet survey, where they talked to the women and then got their male partners to be involved. And they completed the survey between December 2020 and September 2021. Fortunately, for a variety of exposures, whether you were looking at vaccination status or infection in the male or the female, these regression models to estimate fecundability ratio did not show any difference. So basically, the per cycle probability of conception was unchanged by being vaccinated or actually even having infection. There are other studies showing a temporary decrease in fertility among males with COVID-19 infection, but no evidence with this well-done study of any impact of vaccination. They did a nice study with models adjusted for all the factors that you would think would be associated with fecundability. And overall, the population had a 74% vaccination rate. So many of them were exposed to the exposure of interest. So what about first trimester exposure? A lot of the question comes up. We have a lot of data about third trimester exposure and infection, but early in pregnancy is where a lot of us are interested about the impact. And one of the best populations to do this in is in people seeking assisted reproductive technology, because they're so closely monitored and watched from the preconception period through the early pregnancy. You can get very good outcomes on these things that are of interest. So this is a newly published in OBGYN this month, a retrospective cohort study at Mount Sinai in New York, where they focused on women who had ovarian stimulation or frozen embryo transfer between February and September of last year. And they compared between 222 fully vaccinated women prior to the stim or the transfer to 983 unvaccinated women, and found no statistical difference in the outcomes, whether you looked at any of the outcomes listed here: pregnancy, clinical pregnancy, ongoing pregnancy. This is the type of data where if you have a patient who's interested in talking about data, this is reassuring that in this closely monitored group of patients, there was no impact of vaccination on these outcomes. So what about specific outcomes in pregnancy? We are learning more and more. In the early days, we were having case series of 8-9 patients making it into AJOG and being published because we were all so hungry for new information. Right now, we have nationwide cohort studies. So this is a new one published in November in 2021, a national cohort study in England that included women between May 20 and January of 21 who had or did not have laboratory confirmed SARS-CoV-2. So they had 3,500 lab confirmed cases among 342,000 women. And I didn't highlight the significant associations because most of them are significant. What you see is that SARS-CoV-2 is associated with fetal death, preterm birth, preeclampsia, elective cesarean, emergency cesarean, prolonged maternal length of stay, needing NICU care, prolonged neonatal length of stay. All of these outcomes, not just a single one, are associated in a well-done study with SARS-CoV-2. So when our patients ask us, is it a big deal if I end up getting COVID in pregnancy? Most people I know who get it are not very sick. This is good data to say it is a big deal. Every reason to prevent it, because you don't want these to happen. In order to comment on what's happening from the Alabama perspective, UAB is always great about looking at what's happening and sharing data with the world. This was a study led by Dr. Seasley and Dr. Subramanian, where the comparison, what was being seen, as you all know, is a real difference in the summer, where many of the pregnant women being admitted with COVID-19 were ending up in the intensive care unit. So the obvious research question is, are there maternal and perinatal outcomes that are distinct with Delta compared to the prior viral variants? And this included 293 pregnant patients who were admitted to UAB with confirmed COVID-19. Of note, the screen positivity had increased during this time from 3% to 15%, reflecting lots of community transmission. All of the women who were included in this report were unvaccinated. And unfortunately, when you look at disease severity, when you look at ICU admission, when you look at intubation, what was being seen clinically absolutely bore out, with adjusted relative risk significantly higher for Delta compared to the pre-Delta viral variants. So when you think about this, you start to wonder, I wonder what's different. Why is Delta acting differently? And one of the things that has been reported with the Delta variant was it was associated with very high viral loads. So the next research project that's ongoing is there an association between the nasopharyngeal viral load for women, pregnant and non-pregnant, on admission and the outcomes that happen to them? Can we use that as a predictor of who's likely to end up in the ICU and who's likely to do well? Or is it true unrelated, where women with a good immune system can have a high NP viral load and not end up having these adverse outcomes? This work is also being led by Angela and Dr. Nathan Erdman, who has all the data on the non-pregnant cohort, which is our comparator group. The latest data is looking at another outcome of interest, which is stillbirth. So this is data just published in an MMWR from CDC, and looking at stillbirth outcomes among 1.2 million deliveries in the US. They had 8,100 stillbirths for a rate of 0.7%. And what you see here is that women who had COVID-19 confirmed at their delivery hospitalization had about a 2-fold increase rate of stillbirth. And when you stratified by Delta, just like Dr. Seasley's data, it was a 4-fold increase in the relative risk. So clearly worse. Delta led to worse outcomes. We don't know all the outcomes with Omicron yet. Hopefully we'll see a diminution of all of these adverse outcomes. But again, in thinking about why is this happening, a new study from Boston is giving us some insight. This is a small case series of 3 cases, 2 IUFD and 1 with severe fetal distress. These were all in Boston in the Delta variant period in August, unvaccinated women. Importantly, I want to note that they had mild COVID-19 in the 3rd trimester. It doesn't always take severe COVID-19 to have severe outcomes. It was on average 5 to 10 days between the infection and the outcome. And this is the gross pathology showing you pale mottled parenchyma. And when you looked microscopically with the H&E stain, you see the typical findings of placentitis with the intervillositis, with the histiocytes. You can see the fibrin deposition, I hope, on your screen, and the villus trophoblast necrosis. And when you do the in situ hybridization, looking for the viral RNA, you can tell exactly where that virus is located. So this is helpful. This is not likely a common outcome, but it's important to consider in design studies that can look at this moving forward as we try to understand what's driving the stillbirth rates with COVID-19. So much to learn. For the people that ask you, does it make any difference to the fetus if the mother gets infected or is vaccinated in terms of antibody levels? The answer is yes. We now have good data. This is a Nature Communications paper that came from an intramural NICHD lab, and they looked at maternal blood, IgM, the acute phase, and IgG, the chronic phase, and then cord blood, IgM and IgG, comparing women who had mild COVID and severe COVID. And what you see, no matter which antibody you're looking at, there was good level in the maternal blood, no IgM obviously in the cord blood, but good levels of IgG passing into the cord blood. Interestingly, the woman with severe, or the patients with severe disease had slightly lower levels of antibodies compared to the ones with mild disease. So you don't have to be incredibly sick with COVID-19 to develop antibodies that will be protective. And this is particularly relevant. I don't know if you follow the pediatric COVID vaccine story, but the mRNA vaccine in 2 to 5-year-olds is not working. They need to do additional dose finding studies to figure out how to protect that younger age group, which is to say it's going to be some time until we have a vaccine that's available for 6 weeks, 12 weeks, 24-week-old infants. And this is a great way to provide some protection, with a lot of studies needing to be done about the durability of that infection. It crosses into the breast milk too, as you're all aware. So what are the treatment options? January 2022, I'm happy to report that with millions of dollars invested and many, many scientists working around the clock around the world, we have some great options right now to use. So the 3 I want to focus on are these antivirals: Paxlovid, remdesivir, and molnupiravir. Paxlovid is the newest kit on the block, just approved with an EUA from the FDA at the end of December, authorized for the treatment of mild to moderate COVID-19 confirmed in adults and pediatric patients above the age of 12 who are at high risk of progression to severe disease. The purpose of these oral antivirals is to offer them early to keep people out of the hospital. This is something we've been begging for and hoping to have the whole time in this pandemic. The mechanism of this drug is to inhibit the viral protease called Mpro. And the reason this is helpful, this is not a viral protease that mutates very frequently. It's not the spike protein. So the expectation is that this Paxlovid will continue to be effective with future variants, no matter how the virus mutates. This will have to be studied, obviously, but with the mechanism, it's very reassuring. It is a substrate of the P450 3A4 chondrochrome system, which means you need to consider drug-drug interactions. The efficacy is impressive. A reduction in all-cause mortality in published studies to date through day 28 has a relative risk of 0.04. And the reduction in the hospitalization risk is about 85%. So this is terrific. Keeping people out of the hospital is definitely a good goal. And these pills are relatively easy to prescribe. It's a combination pill with nirmatrelvir and ritonavir, so it's 300, 100 milligrams PO/BID for 5 days. You do want to start within 5 days of symptom onset, and I'll explain with the graph later why that's so important. The availability, unfortunately, is still limited. So I recommend for you to check the Alabama Walmart pharmacies. This week, I'm finding it for my patients at the Walmart in Center Point. Last week, it was the Walmart in Bessemer that had supply, but it does vary depending on when the shipments come and how quickly it runs out. These drug-drug interactions I want to tell you about, the most important ones are anti-epileptic drugs, antiarrhythmic drugs, and psychiatric meds, including for severe schizophrenia. So not meds that the average woman is going to be taking, but you do want to do a drug-drug interaction to make sure there's not going to be an impact of those co-administration. A resource I can recommend for you that we use all the time in HIV and hepatitis C is a University of Liverpool website where you can plug in what the patient's on, and they tell you right away if there's an issue or not. They have it all updated for COVID-19, so it's easy to do. And you know, the pharmacists are also excellent at doing this for you as well. So have them help you if you're not sure about the interaction. It's important to say that because this is so new and because we don't study new drugs in pregnant women, we have no data on use in pregnancy. I'll get at the end about what MFM is saying about this drug, but it's very exciting to have this advance. So the next drug is remdesivir, a drug that preclinically was actually developed in Dr. Whitley's lab at UAB. I know you've heard about this. This is an IV drug that initially had some promise for inpatients in reducing the duration of hospitalization by about 24 hours. There's a new study and now a new indication to use it for ambulatory patients, again with mild to moderate disease and high risk of progression. It's 200 milligrams followed by 100 milligrams on day 2 and 3. IV, obviously a little more complicated to administer than the pills at home. And this is based on this new New England Journal outpatient study called Pine Tree. They enrolled 562 people who had confirmed COVID with symptom onset less than 7 days, at least one risk factor for disease progression, and a mean age of 50. And when you look at this hazard ratio for COVID-19 related hospitalization or death from any cause, even within 2 days, you already see a difference between the placebo group and the remdesivir group, showing significant protection of the remdesivir compared to placebo. So another great option. There's been discussion about what to do with remdesivir because after the initial inpatient studies were favorable, some of the subsequent studies have been less favorable. So it's not used quite as often in the inpatient side, but this may be a great niche for this drug that we do have some pregnancy safety data on. This was a drug that was used in Ebola, so we had some earlier pregnancy data on it as well. The reprotox information is reassuring. Based on the molecular size, it's not likely to cause the placenta. In pregnant and non-pregnant people, there's a mild elevation in LFTs to watch out for. It's approved for use in mild renal insufficiency, but not people with a creatinine clearance less than 30. In a drug study compassionate use program with 67 women who received remdesivir in the 2nd and 3rd trimester, 67% of whom were in the ICU. Most women recovered, 93%. There was no comparison group, but they did comment that 69% had preterm delivery between 24 and 32 weeks. We know the severity of outcomes in women who were admitted to the ICU with COVID-19 and pregnancy. So it's hard to know if this is a drug association. It's thought not to be, but obviously bigger studies with the comparator group are going to be needed. And then the third, molnupiravir, there's some really important facts about this I want to make sure you are aware of. This drug was developed at Emory. The preclinical trials were developed at Emory. So this is another new oral antiviral, these red pills, 800 milligrams for 5 days. This is the Merck product. It has some important limitations, and that has to do with the mechanism. The way this drug works is with mutations. It causes mutations within the viral reproductive cycle in the RNA polymerase, and it's not as effective as Paxlovid is. The reduction in hospitalization, the relative risk is about 0.68, so much less effective than Paxlovid is in these early trials. And unfortunately, based on the preclinical studies, the rabbit model and the rat model, it may cause fetal harm. There's a recommendation to not use it in pregnancy, to avoid it in under age 18 due to possible bone and cartilage effects they saw in the animal models. Women of reproductive age should use contraception during treatment and for 4 days afterwards. And men with reproductive age female partners should use contraception during treatment and for 90 days afterwards. So because of these concerns, because of the reduced efficacy, I really think that Paxlovid is going to take off and hopefully be manufactured in a way that will have enough supply soon to be able to use for our patients. The next thing to talk about are anti-inflammatories. And I think to explain anti-inflammatories, it's helpful to think about the stages of COVID-19 disease. So in any viral infection, if a respiratory virus is going to make you critically ill, the viral load peaks before you even have onset of symptoms to 2 to 3 days after you have symptoms. If you have a good immune system, that virus is going to be cleared between day 7 and day 14. As the virus is cleared, your body ramps up and tries to clear the infection, leading to this very vigorous inflammatory response and cytokine response that can lead to adverse outcomes. So the principle here is that if you are going to use an antiviral drug, you need to use it early, because giving someone an antiviral at day 21 is not going to help them unless their immune system is weak again. And maybe giving people anti-inflammatories at the later stage when they're critically ill is more reasonable and would expect it to have more of a benefit. So you know the story of dexamethasone. This has been shown to be effective, an inexpensive drug used around the world for 10 days, effective in severe disease. The other drugs that have some efficacy are IL-6 inhibitors, tocilizumab, seralutinib, and JAK inhibitors. Baricitinib is probably the one that you've heard of. Tofacitinib also has trials. So these are not drugs you're going to use on patients who are not in the hospital. These are drugs being considered by the ICU teams when patients are incredibly sick to prevent them from dying. We don't have any pregnancy data on the latter two groups, although there are efforts to try to get some of that data. What about monoclonal antibodies? I know you're getting asked about this all the time. This is a very popular topic in the public. And I think that to understand the monoclonal antibodies, remember on this virus, these floating green spike proteins with the trimeric structure is what we're thinking about for the virus. The virus uses that viral protein to attach with these cellular receptors on the epithelial cells in the nasopharynx with the ACE2 inhibitor and with the co-receptor of TMPRSS2. So the purpose and the way the monoclonal antibody works is it was specifically engineered by the drug company to the native virus, to the native spike protein, to bind closely to that green spike protein and prevent this attachment and viral entry into the human cell. So when you then think about the changes that Dr. Lee was talking about with the Omicron variant, I have for you a picture of the EM, the cryo-EM, of the actual protein structure with the folding. And the red area shows you the area of mutation for Omicron compared to Delta. And it's not surprising that many of these mutations are on the RBD, or the receptor binding domain. Unfortunately, that means because of this immune evasion, immune escape of this new variant, our old monoclonals do not work anymore. So if anyone's asking you why the FDA is taking these old monoclonals off the market, not so old really, but the prior ones that we were talking about, the reason is they don't work for the currently circulating strain that's in 99.9% of the country. We do fortunately have one option or a couple of options. The monoclonal antibody with efficacy against Omicron is sotrovimab. The efficacy is a reduction in hospitalization with a relative risk of 0.14. We don't have pregnancy data for sotrovimab. We do have pregnancy data for the earlier COVID monoclonals, and the safety and efficacy was good. Some of these were published case series, case reports in the literature. You may hear about another combination monoclonal antibody called Evusheld. This is a long-acting, used as a pre-exposure prophylaxis and really indicated for immunocompromised patients, someone who had a stem cell transplant, who has no T cell function whatsoever, who will be immune depleted with a low ANC below 400 for a period of months, who you can vaccinate, but they're not going to respond to the vaccine. The Evusheld is to give that person 3 to 6 months of protection in case they get exposed to COVID-19. So sotrovimab is really the one for you to be familiar with right now. And the supply of sotrovimab is also low, hopefully will increase, but for now, this is from our COVID-19 treatment guidelines at UAB. You can see for a patient who's COVID positive with less than 10 days of symptoms, the tier 1 highest priority category, group number 2 is pregnancy, women who are unvaccinated with moderate symptoms. They are first in line to get this preferred, second in line to get this preferred therapy if they've had less than 10 days of symptoms, with Paxlovid listed as an alternative therapy due to the lack of pregnancy data. What are the COVID-19 treatments to avoid? These are the ones that people, talk about something they saw on Facebook. And I've heard of people, pouring boiling water with a Netipot through their sinuses to kill the COVID virus. So lots of things you shouldn't do. This list on the left are drugs that have been studied, some of them, many studies, not showing efficacy. So none of these are recommended. This is the potential for harm with no expected benefit. And then the drugs on the right are untested, unproven to be used in the setting of a clinical trial. We have more to learn. Fluvoxamine had some early promise. This is an oral antidepressant medication that had some efficacy in keeping people out of the hospital, but we need better studies, just as well as all those other agents there. I think this is such an exciting space because there are 603 active treatment trials of COVID-19 right now in the NIH reporter. So this will continue to evolve and grow, but remember, treatment is always secondary to preventing infection in the first place. So every time someone asks or you think about protection, the best COVID-19 prevention tool we have is obviously the mRNA vaccine. Looking at time, I think I need to make sure I get through all these slides. So the safety data that we have for the vaccine in pregnancy is excellent. This is CDC data looking at 10,000 vaccinated women at 8 very large healthcare organizations, mostly vaccinated in the first trimester and mostly getting mRNA vaccine. When you look at preterm birth, when you look at SGA outcomes, no association with vaccination. If anything, in some measures, there is a benefit in preventing preterm birth with vaccination. Certainly no evidence of harm. When you look at vaccine efficacy and antibody titers, this is the study that I showed to people who were questioning about the booster dose. This is a study that was done in Israel, where they have nationalized healthcare systems and databases where you can do large studies. It was limited to adults age 50 and up between August and September 2021, who were at least 5 months from their second dose of the Pfizer mRNA. They've only used Pfizer in Israel. And you can see, again, at 18 days, this difference in the cumulative hazard ratio for death when you compare people who got that booster to the ones who did not get the booster. So particularly for patients who were at risk of having the waning, the booster is very important. This study also showed a hazard ratio for death for male sex compared to females. It was a 50-50 study of 2.5. So importantly, the booster is very important for males. And part of the reason for that may be on this study here. So this is a New England Journal article, also from Israel, looking at monthly antibody titers after the second dose of the Pfizer vaccine. And just to focus on the neutralizing antibody, which is the one that you care about, this gives you about 2/3 of the protection against COVID. There is a significant difference in neutralizing antibody levels in younger people less than 45 compared to people above 45 and especially above 65. And when you compare males to females, whether you look at peak titer or the end of study titer, males had lower antibody levels. So particularly important to get boosted if you're in these groups. So what is the COVID-19 vaccine uptake? We can say among women, it's a little higher than men. This is US data current, 65% of females, 61% of males fully vaccinated. And these are the age groups on the bottom. The light yellow line is young children. The darker yellow line is age 12 to 17 with 65 plus in pink. So lots of variation among women by what age group they are. And when you look in pregnancy, fortunately, over time, we have many more women who are now vaccinated. Most of them are in that blue category. They were vaccinated prior to pregnancy, which makes a lot of sense. But it also makes you start to wonder, if they were vaccinated prior to pregnancy 12 months ago, then is there waning? Do they have enough of an immune response while they're pregnant today, heading into the rest of their pregnancy, to really protect them? That's a question that we still have to answer. And we still have important racial disparities in the COVID vaccine uptake rate. This shows you all races and ethnicities in yellow, Asian, non-Hispanic in red on the top, and Black, African American on the bottom. So we need to do better at making this equitable, both our access and answering questions about vaccines for our patients. How do you address this COVID-19 vaccine hesitancy? I know you're facing this every day. I wanted to give you some data to say you are not alone. We did a study of vaccine hesitancy among pregnant women in Cameroon, a survey of 835 people. And what we found when we asked them, this was this summer, we did it June, July of 2021, would you take the COVID vaccine if it was available today? This was after it was available in country. Look at the large percentage that said no or not sure. 9% of women said yes, 9.3% of women. And unfortunately, as of this week, the national vaccination rate in Cameroon, partly a reflection of inadequate supply for adults, is 4.7%. So it continues to be way too low to have the protection that we want. When we dug a little further to ask women what their thoughts and concerns were, many of them, if you look at the green is agree, the bright green is not sure, and the gray is disagree, think the vaccine doesn't work, are not sure whether or not the vaccine is harmful in pregnancy, aren't sure about the infertility association. And importantly, a lot of people thought that the vaccine they could get in Africa is not as effective as the vaccine that's administered and delivered in Europe and other parts of the world. So this gives you some answers about how to proceed and how to think about addressing people's concerns going forward. I think the silver lining is, like, just like the US, 90% of women, when they were asked, said their most trusted source of information about COVID-19 is their healthcare worker. It's their doctor, it's their nurse. Those are the people that they want to hear from and listen to about this. So that is sort of marching orders for the rest of us. I will keep going unless someone wants to cut me off. I just have a few more slides. This is the example of the life cycle of a COVID-19 vaccine lie, an article from NPR a few months ago. And I think it's interesting to start with a kernel of truth. When it comes to the question about infertility with the vaccine, there was a Pfizer scientist who hypothesized in a very public way that there was an association between SARS-CoV-2 spike protein antibodies and the syncytin-1 antibody that would impact placental development. That led to a lot of speculation, a lot of fear, a lot of disinformation. And fortunately now, many months in, we have good studies showing zero cross-reactivity. This was an absolutely made-up claim. The proteins don't even look the same. So this doesn't have any basis in fact. And another thing that was very popular on Twitter and on Instagram and on Facebook was women who were reporting changes in their menstrual cycle after they were vaccinated, in the duration and the severity, in the amount of menstrual cramps associated with menstruation. So they pushed to the level of the NIH saying, we demand this question be answered, which is relevant and appropriate. Fortunately, this study, the first that was published of many, of about 4,000 women just this month in OBGYN, did not show a significant change in the adjusted model in cycle length, and did not show a change in the length of menses itself, comparing women who were vaccinated and unvaccinated. So we don't always have data on our hands immediately when the questions start to pop up, and they pop up from everywhere every day. But with careful thought and good planning, we can develop the right studies to answer these questions so we can have good data for our patients. And ultimately, that's where I want to end. I think what we need to do is improve the evidence base for women in pregnancy for COVID-19 treatment and prevention. And these organizations are doing an incredible job, as you know. SMFM, this is the point I wanted to mention. Their statement on December 22nd says Paxlovid should not be withheld from pregnant women who need it even though we don't have pregnancy safety data yet, they said this drug is so important and this disease is so devastating. Let's do both at the same time. Let's treat and study at the same time with an informed consent discussion with the woman and what her decision making is. That conversation you all know how to have in that room. I'm a member of the COVID-19 task force of the American Society of Reproductive Medicine, and we've worked hard, just like all these other organizations, to craft documents that are evidence-based to address the common concerns and give people guidance about what to do when all these flurries of new studies come out every week. There's also a national level push from the NICHD, from the National Academies of Medicine, and from the FDA. And these are my 4 conclusion points. Compared to men, women have higher rates of infection, but lower rates of critical illness. We know pregnant persons with COVID-19 have higher rates of ICU admission and mortality compared to non-pregnant women. We need to clearly encourage vaccination in all our patients, including booster doses. Address their concerns and misinformation. Early treatment with these effective antivirals is now available, but the supply is short for the moment and pregnancy safety data still has to be collected. And we only will get that with inclusivity in clinical trials to improve our evidence base for treatment and prevention. So with that, I wanted to thank the members of the terrific UAB CWRH COVID-19 and pregnancy work group, and then the people on the bottom who are working on this new viral load study. And I think if I've left a minute or two, Rachael and I would be happy to take any questions that you have. Thanks for your attention.
Thank you guys so much for talking to us today and giving us some updates. And I guess just to echo what Dr. Dionne said, anybody have any questions?
Akila, it's quite hard to hear you.
Oh, can you hear me?
Better. That's already better. Yeah.
I was just saying thanks to you guys for coming to talk to us, and with that, I'll take your questions.
I left -1 minute for questions. Sorry, everybody.
Rachael and Jodie, great job. And it was very good. Very good.
Thanks, Ricardo.
Thank you.
Love to get this the lecture circulated if we can. We have other parties, as you know, Jodie, that need to learn more about pregnancy, COVID and pregnancy. So great.
Totally agree. Totally agree.
Yeah, feel free to share.
I have a quick question. I'm starting to hear, as I'm probably many of you are as well, on the news that we're getting close to an endemic period and the pandemic may be ending. Can you guys speak at all to that? So I don't have to rely on the evening news for my data.
Yeah, gave me the hard question. It's really hard for me to think about endemicity when we're still dealing with massive surge of patients. You know, endemicity essentially means that it is regular and you can predict when you're going to see cases. Like with flu, you can predict between October and March that you're going to see an increase and then subsequently a decrease in cases. We have not had that. We have had surge after surge after surge. I think the hope after we get out of the surge that potentially we'll see some endemicity, but the key there is that you have to have regularity and some way to get into our kind of our winter season with that. So I would say too early to say anything.
Just to add to that, Ashley, what I've heard from the virologists is yes, oftentimes respiratory viruses mutate to become milder, but not always. You can't predict how it will mutate. The next variant could be easy to transmit and very deadly. There's no way to be sure. A lot of the viral evolution is probably happening in patients who are immunocompromised, where you can detect the virus for as many as 200 days. That's a lot of time for the virus to mutate and change and find a way to continue to infect as the population becomes increasingly immune to the prior variants. So you need a crystal ball to be sure.
I have a quick question with regards to the pregnancy outcomes with COVID, and if there's a word for some standardization of screening and antenatal surveillance for women who are COVID positive pregnancy. And that might be more for the MFMs on the call. Sorry if it's outside of yours.
Yeah, I think I'll let Akila address that.
I mean, I guess to that the simple answer is no. Nobody really knows what's the optimal antenatal screening. I think different institutions are doing different things. Some are looking at whether there's blood restriction, Dopplers, et cetera, but there's no standardization to based on when someone's infected, how long, nobody knows.
Obviously, Jodie, the other issue is that, like I mentioned before, we still have this paucity of data around first trimester exposures. So a lot of people are thinking about how to create larger databases to capture that, because I would say 90% of our studies are looking at COVID-19 at the time of delivery or at the time of admission, when the patient's already 35, 36 weeks. So much we need to learn about early exposures.
Thank you, guys.
All right.
Akila, it's Friday afternoon. I think everyone's ready to
go, yeah.
back to 4,000 other things.
Yeah, so I guess with that, thank you guys again for coming to chat with us, and then everyone have a good afternoon. I'll turn it over to the rest of the team for the rest of the afternoon session. Everyone have a good afternoon.
Thank you.
Thank you.